All right, well, welcome everyone to the American Ambulance Association's Ambulance Cost Education's most recent uh, cost data presentation titled the CMS Ambulance Cost Data Collection in 90 minutes. And we're going to hold you to that presentation. My name is Brian Werfel, and I am the Medicare consultant to the American Ambulance Association. With me today, I have Katie. Katie, would you like to introduce yourself?
Certainly. Thanks, Brian. So I'm Katie Arens. I am Vice President of Customer Access here at Life EMS Ambulance in Michigan, and also a part of the Ambulance Cost Education faculty.
All right, so before we get started, I do want to thank all of you certainly that are attending today. In addition, our sponsor, the SAVIC Foundation and the SAVIC Buying Group, they've been amazing partners, and I'm sure we will talk about them a lot more when we get to a later part of the presentation, because they've helped create and push out to the industry our Amber accounting project program, excuse me, which will hopefully make your lives a lot easier in terms of gathering up this data and reporting it. So um, before we go further, this is approved for credits through the National Academy of Ambulance Coding. So make sure that if you do participate in one of their programs, that you do get your credits for today's presentation. And as Katie indicated, we are just part of a faculty, a much larger group of people that have spent a good chunk of the last probably 5 years at this point, going through both the preparation for and the early stages of the cost data reporting. So certainly we've blessed in this situation to have, roughly half the industry already through this. So certainly we are in a position to anticipate most of the problems that many of you might think you're going to encounter. And what that means is that we do definitely encourage you to make use of that chat feature, just to ask any questions that come up as they come up. We'll certainly do our best to answer them online. If we can't, we'll commit to making sure that we get you a written answer as soon as possible after the presentation concludes. So we did discuss the SAVIC Buying Group. They were instrumental in helping us develop our ambulance cost collection tool, which we've called Amber. And in addition to helping us develop it, they've sponsored it and committed to making it free to any ambulance organization that would like it. So if you go to that link on the right over there, you can log in and request access to Amber. And in doing so, you will also get a complimentary 1-year membership to the American Ambulance Association and all of our other educational products. So we do hope that everyone does take advantage of that. Disclosure, while I am an attorney, I'm appearing here as a representative of the American Ambulance Association, and that means it's consultants and speakers. We are not technically providing legal or accounting advice. This information is for informational purposes only. If you do have any specific questions that require legal, financial, or accounting advice, we would certainly encourage you to discuss that with your own professionals. All right, so before we get into the cost tool itself, we thought that it probably makes sense to just take you through the broader context, just to help you understand what it is that CMS is trying to accomplish with this program. Then we will go through the actual collection piece itself. It's divided into a number of different sections, and we'll discuss each of those sections in greater detail. And then at the end, we will just sort of give you a brief walkthrough of the Amber product itself, just so that you could see how it's used and just to make you aware of certain features that, in our experience and the experience of people that have used it, will make submitting your cost data just that much easier. So with that in mind, why are we doing this? Probably the most common question we get. It's a somewhat complicated answer, but the short version of it is the consensus within the industry that Medicare's reimbursement is no longer adequate to cover the costs of providing EMS. Nationwide, we believe that's true, but we believe it's particularly true in rural areas, which Montana certainly would qualify as having its fair share of. Historically, this under reimbursement of Medicare has been addressed through legislation passed in Congress that gives extension or temporary relief. This is the 2% bump in the Medicare allowed amount for urban, the 3% bump in the allowed amount for rural, and the 22.6% bump over the rural 3% that many of you get if you operate in super rural areas. But what's happened in the last couple of years is that Congress's appetite to simply extend what are called these Medicare extenders without underlying data has sort of changed. So in the last extension, or to be more precise, the second to last extension, a deal was struck that indicated that while they would extend it for a period of time, and at the time it was 5 years, it's subsequently been extended for another 2, but at the time they extended it there, they said that any future extension would be subject to formal cost collection data. So basically, Congress just wants to see where the industry truly is financially before it makes a decision on whether or not any relief is required. Now, they had attempted to collect cost data on the industry in the past. Specifically, the Government Accountability Office, the GAO, did 2 studies, one in 2007, looking at what would be the financial landscape in 2010, and then a second report in 2012, looking back on what actually happened in 2010. The problem with both of those reports, though, is that the GAO did not have the authority to mandate compliance. Rather, they did it through a voluntary survey method. They mailed out questionnaires to selected ambulance providers, several of whom responded, many of whom did not. So as a result, there's just not any confidence that those survey results accurately reflect the financial health of the industry. That's where this cost reporting process comes in, because as a congressional mandate, they could build in an enforcement mechanism, and that enforcement mechanism is a penalty if you don't submit your data when it's due. Specifically, it's a 10% cut in the Medicare reimbursement you would otherwise be entitled to for the year in which, well, the year after the year in which your cost data was due. So presumably all of us on this call today will anticipate submitting our reports in 2024. So that would mean if you don't submit, you would be subject to that 10% penalty in 2025. So part of our goal today is to convince you that it is in your interest to submit this data. One, we don't want to see anyone take a 10% cut. But 2, the industry is all over the map in terms of the types of providers. And historically, when they've attempted to collect cost data, the responses that the government received tended to skew towards larger and urban providers. And that's not truly representative of the industry itself. The vast majority of the industry are small and in many cases rural providers. So for instance, 90.6% of EMS services billed less than 2,500 Medicare transports in calendar year 2021, or less than about 200 or so trips a month. And 81% or 82% of the industry billed less than 100 Medicare trips a month. By contrast, the average provider that would reply to those surveys billed in excess of 10 to 20,000 Medicare trips a year. So they're truly not representative. And it's our belief that all things being equal, the smaller you are, the higher your average costs, meaning those small services not only represent the vast overwhelming majority of the industry, but we also believe that they have costs that are significantly higher than what's been represented in the past through that voluntary process. So we believe that submitting your data, especially If you're a smaller service, will not only help you avoid that 10% cut, but will also help the industry as a whole justify the increase or the increases that we're looking for. And again, we're not looking for anything radical. We're not looking, for a windfall or anything like that. We're not being greedy. We simply want to make sure that Medicare is covering the costs of the average EMS provider. There's one other piece of this, and that is, frankly, it really undercuts the argument that we need help if the provider community is not willing to submit their data, right? So it looks somewhat ungrateful. So we're trying to avoid that as well. So we got here, again, as I mentioned previously, through a provision within the Bipartisan Act of 2018 that not only extended our existing 2%, 3% and super rural bonuses, but it mandated the collection of cost data and a report by MedPAC, which is the Medicare Payment Advisory Commission. It's a nonpartisan think tank that reports to Medicare on reimbursement matters. It was required to submit a report by March of 2023, but of course, COVID intervened, and as a result, subsequent legislation put that deadline back to, and it's a little bit complicated, but the new deadline for the submission of the MedPAC report is no later than the second June 15th, which follows the date on which HHS or CMS first gets its data, meaning the data that was submitted as part of the cost reports, over to the Medicare MedPAC. So it would be at the earliest June of 2025, but more likely it would be June of 2026 is when the report is due, but there's no requirement that they wait until the last minute. So it is entirely possible that they may submit their report this year. It is unlikely, but it is possible. More likely that they would submit it sometime next year, and that means that the data that we're talking about submitting today would likely be included in that report. What happens if we don't report accurately is another common question. Well, if you don't report, you will be subject to the 10% cut. If you don't report completely, you may also be subject to that 10% cut. If you don't report accurately, which means you did complete data for each of the requested fields, but frankly, it's not accurate, there's likely going to be no immediate consequences. It is highly unlikely that they would audit reports for accuracy. There's simply too many ambulance providers out there and not enough time, frankly, to go through those audits. But it could paint a false picture on your financial health. So this brings us, I think, to probably our first tip in terms of as we go through the report. And that is, while we want to be as accurate as possible, there may be situations where you're forced to make an estimate, and that's okay. So what we don't want is to let perfection be the enemy of the good here. This is not like your tax report or your tax return, where it dictates the amount of taxes you owe. This is more, a situation where your data will be aggregated with thousands of other providers and then examined. So certainly close enough is good enough for these purposes. So just keep that in mind as we go through some of the specific fields. And then when you get down to actually submitting your report, don't get hung up on something, if you can only get a rough estimate, that may be okay. And as we go through the data collection instrument itself, what you're going to see is that there are some fields that by their very nature don't lend themselves to 100% accuracy. They almost require you to make certain assumptions. So timeline. So the initial timeline was altered by COVID, but the current timeline under which we're operating on is that there are 2 data collection periods, or years rather. Those are calendar years 2023 and calendar years 2024. Those, sorry, I said that wrong. It's calendar years 2022 and calendar years 2023, right? And then within those calendar reporting years, you have to select your own reporting period. Your reporting period is a 12-month period that either begins on the first day of the calendar year, in which case you're what's called a calendar year filer, or it begins on the first day of your particular fiscal year, if you operate on a fiscal year. And it's for the fiscal year that starts during the reporting year in which you're selected. So presumably all of us were selected for the 2023 reporting year, and therefore we're getting ready to, and we're operating on a fiscal year, and therefore we're getting ready to submit during that. So if you elected the calendar year, you would collect data for that 12-month period. And then following the end of that calendar year, you would have 5 months to submit your report. So if you were filing based on calendar year 2023 data, your data is due no later than the end of May 2024. If you elected a fiscal year, and a common one for municipal agencies is fiscal years that begin in July, and you're in the 2023 reporting year, then your 12-month reporting period started on July 1st, 2023. Now, what that means is you'll continue to collect data through the end of June 2024, and then you would have up to 5 months to submit the report, meaning no later than November of 2024. And if the off chance that your fiscal year is something other than like a July, I know there are some municipal entities out there that use October calendar years. That may mean that your 12-month period is running from October of 2023 to September of 2024, in which case your report will be due by February of 2025. I know that's a little bit confusing, but we can certainly answer questions about your specifics situation. So we do have some resources out there through the Ambulance Cost Education website maintained by the American Ambulance Association. And in addition, on the right-hand side, you're going to see certain CMS resources on cost data. One that I think should be mandatory would be to download the printable version of the CMS Medicare Ground Ambulance Data Collection Instrument. That is a printed version of the specific questions that you will be asked when you log onto their portal to submit your data. But as you're preparing for and gathering up that data, it's certainly going to be helpful to have that in front of you, just so you can know how to organize the data you're going to collect. In addition, on the ACE side of things, we have numerous webinars that not only go through the cost data process itself, similar to what we're doing here, but we have specific videos that are dedicated to specific sections of the tool, and therefore it allows us to go into it in much greater detail. And you'll see that as we go through the specific fields, there are certain fields that, depending on the type of EMS agency you are, whether you're public or private, whether you share a mission with some other public service, for instance, fire departments have both an EMS and a fire suppression mission, and therefore have shared costs. You're a shared service model. That will complicate the reporting to some extent. We have videos that will help walk you through how to make some of the allocations that would require. I believe we touched on this, but if you operate on a fiscal year, your reporting timeline is the 12-month period that's based on the first day of that fiscal year, and then you have 5 months from the end of that fiscal year. Now, the way this worked is your MAC, and more recently Palmetto on behalf of all of the MACs, would have reached out to you and asked you to reply back to them to let them know whether you intended to report on a calendar year or a fiscal year. If you're on a calendar year, that is the default. So whether you responded in the past or not, you're still going to be on a calendar year. I don't think there's anything that's necessarily required on your part. But if you do intend to use a fiscal year, it is very important that CMS and its contractors understand that you're using a fiscal year. The reason is because, let's say you're using that July fiscal year, then your fiscal year will close in June of this year, and your report isn't due until November of this year. But if you accidentally elected a calendar year, or if you didn't respond and therefore defaulted to a calendar year, they will expect your report by May of this year. And when it's not delivered by May of this year, they may inadvertently impose that 10% penalty. So as a best practice, we would suggest that if you intend to report based on a fiscal year, that you do reach out to Palmetto to confirm that they show that you're on a fiscal year and that, you know, the fiscal year matches the month in which you intend to start that fiscal year. So just a best practice there. I've heard that services can file for a hardship exemption. Is that true? It is true, but not in the way most people intended it. So by hardship here, we don't mean you can file a hardship and not have to report your data. That's not the way this works. Rather, it's if you don't report your data, you will get a letter from your MAC informing you that you are being subjected to the 10% penalty next year. It's at that point that you could write back to them to request a hardship. A word of caution, though, CMS has been fairly clear on this point, and that is hardships are going to be granted only in the most extreme of circumstances. So, for instance, on a number of open door forums, people have asked them if a natural disaster, such as a flood or a wildfire, would justify a hardship, and they've uniformly responded that no, it wouldn't. And their logic is, while the flood may affect your operations for a month, at most, you still have 15 months to get the report in. So we don't really see that as a hardship. So what do they mean by hardship? Something along the lines of the building in which all of my financial records exist burned down. So if your situation is just simply that it was really difficult to get it in, unfortunately, no, I don't think you're going to qualify for a hardship. If you want a good example of this in the real world, a very large provider, very large, I mean, in excess of 100,000 trips, was getting ready to submit their cost data report, and the individual that was responsible for submitting it was in a car accident and was hospitalized for 2 weeks. As a result, they missed their deadline, and they received a letter indicating that they would be subject to the 10% cut. They attempted to apply for a hardship and were not granted it. However, they did subsequently submit the report, and they were able to convince CMS to waive the 10% penalty. But they waived it not because they granted them a hardship, rather because they ultimately had their data. So don't think that this hardship is a get out of jail free card. They want to see these reports. And then is there anything I can look at that tells me what I need to report? That would be that CMS data instrument, which again, we would encourage everyone to submit. Last question. We don't do a lot of Medicare. Couldn't we just take the 10% penalty? You can. We would encourage you not to, because the type of provider that would see taking a 10% cut as a tenable solution is probably the type of provider that we would love to have your data, because it would help us make the case that the industry is under reimbursed. You know, but no one's going to force you to submit it. So ultimately, it is a business decision. We hope that you would, you know, at least give it a shot. And if it's not too big a burden, submit the report. But there will certainly be providers out there that elect to take that 10% penalty for sure. With that, I'm going to turn it over to Katie to start walking us through the actual sections of the instrument.
Thanks, Brian. And just as a reminder, if you just joined us, but if you have any questions, go ahead and throw them in the Q&A box as we're going through the sections, and we'll either answer them real time or we'll answer them right in the Q&A box as well. So we'll go ahead and get started actually diving into the tool itself. There are 13 sections. It consists of 45 pages. And we're going to go through each of those sections today at kind of like a high level overview. After today, if you have questions, as you've also received a copy of the slides in the chat, just let us know, reach out to us in the faculty, and we'll be able to follow up with you at that time. So we'll go ahead and advance. Brian, I'll have you start, unless you want to give me permission. There you go. Thank you. Okay, so section 1 of the 13 sections is the best section by far. So this is just basic instructions of the instrument itself. It's going to give you kind of a quick overview of why you've been asked to submit this information, inform you that it could take up to 20 hours to review the instructions, collect the data, and then an additional 3 hours to enter and submit it. And then just as a reminder, it's letting you know that they only want you to provide data specific to the MPI for which was chosen for that collection period, and that this is only specific to ground ambulance organizations and provider types. Section 2.
Sorry about that.
All right, it goes into organizational characteristics. So this is the tell me about yourself. What type of provider are you? There are questions in this section that is basically going to set up for the rest of the tool additional information that they're going to need to collect based on how you report your provider type. So they're going to ask for your ownership type. Are you for-profit, nonprofit, but not government? Are you governmental? Are you public or private partnership? They're going to ask for an organizational contact. So once they receive the data, if they have questions or they need to reach out to you, make sure this is a person that's familiar with the data that was submitted and can assist the caller with their inquiries. You don't want to put somebody's contact info here who doesn't even know that you had to submit or doesn't even know who to reach out to for additional clarification. So, and then they also just ask again here, are you reporting based on a calendar or a fiscal year? Based on the provider type you are or the category, you have to answer, are you a fire department? Are you public or other public safety? Governmental? Are you a hospital-based provider? Are you an independent proprietary provider who primarily provides EMS services or primarily provides non-emergency services? So maybe you don't have 911 contract under that NPI and you're only doing non-emergency based work. If you choose fire, police, or hospital, this is going to set up in other sections of the tool. It's going to look for shared cost, and it's going to want you to allocate out the specific percentages, and we'll talk through some of the calculation measures you can use or metrics you can use going forward to know how to allocate. But if you choose that you are fire, later in the tool, it's going to ask you for shared service model data. And so let's just say you get farther along in the tool and it starts asking you for allocation specific data. So an example would be you're reporting vehicles, and then it asks you, okay, how much of this cost was specific only to ground ambulance responses, or how much of this was specific to fire or public safety? If you're getting those questions and you don't have shared costs, it means that probably in section 2, you might have clicked the wrong box and you need to go back and correct that. Next slide. And there you go. Another example, this is actually a screenshot that we take right out of the Amber tool. And again, it's identifying for you that if you select one of these types of providers or organizational types, you're going to have to enter additional allocation or shared service information later on. So when it looks at costs that are within scope and out of scope, it's specifically looking, thinking back to what's the purpose of the instrument, what's the purpose of why we're doing this today, and it's to get down to how much does it actually cost to operate a ground ambulance service and provide responses and treatments. So you're going to have for like labor, facilities, and vehicles, and even potentially revenue, you're going to have costs and expenses and revenues that are going to be at a high level overview, meaning that they're incurred at the full parent company or the full fire service model. But then specifically, we want to get down into what does it cost for the ground ambulance. So next slide kind of walks us through, if you click through, it will get us through all of the bubbles here. But identifying, how do I know if the expense was actually specific to ground ambulance versus specific to our fire service? So here's an example that expenses unrelated to ground ambulance would include or could include fire specific training, assistant fire chief that didn't have any ambulance duties during that collection period, staff who only work on wheelchair vans. And then also if you operate an education program and that education program is not providing material, training, or assistance to the ground ambulance operation, those expenses are not going to be related or included in the ground ambulance data. Now you're going to have shared expenses. So some shared expenses are going to include dispatch. Maybe you have one dispatcher 911 center and they're dispatching both fire and EMS responses. So that's a shared cost. Fire trucks that also respond as on medical responses, which we'll talk through that later on in a couple other sections. And then you'll have costs that are specifically related to ground ambulance only, and that would include the ambulance costs. So the actual ambulance itself, any medications or supplies that have to be on that ambulance. Again, it's specific to the ground ambulance service. And then ambulance billing is another example as well. So when deciding how to allocate, it's important to understand that you want to make sure that it's data driven and that you're not guessing, that you can explain the method or the algorithm calculation that you chose to use, and that it's closely aligned with the time, the expense, or the revenue that's being allocated. And something else that's important to note is to make sure you're writing it down. So for instance, on the labor, maybe you're choosing to allocate specifically to number of responses. So you look at your total volume and you had 100,000 responses and 50,000 of those were specifically a ground ambulance response. So 50% of your volume, your total volume for the year, was attributed to ground ambulance. So you could choose to say 50% of this expense, because of that's my volume mix, is going to be ground ambulance. You're going to want to make sure that you're writing that down and also the justification for why you chose to do it that way. And then we'll talk through when we look at like facilities. You can also do it just based on square footage, or even, you know, a fire truck takes up more space, right? So you can use an allocation method like that as well. Next slide. Also in this section, they're going to ask for your primary and secondary service area. So you're going to have to report this by zip code. So primary service area is going to be where are you exclusively or primarily contracted or responsible for providing a service, either emergency or non-emergency. Where is the bulk of your volume going to come from? And then your secondary service area, this is going to be, you know, typically when you have like a mutual aid agreement. So you're not contracted maybe per se with that municipality, but the provider that is the primary contracted provider for that area, they may reach out to you regularly to provide a mutual aid response or to seek your assistance because they're not able to cover that response for some reason. You're not going to want to include areas where it's an exceptional circumstance, like you're not typically responding there on a routine basis. And you don't want to include any FEMA or MCI natural disasters or state disasters, those areas either. On the next slide, it goes through, it shows a screenshot in amber where you can actually draw on the map what your service area looks like. That's an option. You can also enter the zip codes individually, or you can also upload a list as well. On the next slide, it answers, or the question can be posed, what if I have a zip code that's in my primary and my secondary response area, right? Like it crosses over, and you can report both in your primary and in your secondary. So on the next slide, you know, I wouldn't get too hung up on that. Go ahead and advance, Brian, to the next one, because ultimately what it comes down to, like, if you're routinely responding to a call within the zip code, I wouldn't get too hung up on it if you need to have it in both. But again, you want to make sure you're accounting for your primary zip code, and also like being, if you're a rural provider or super rural provider, you want to make sure those codes are correctly reflecting the service area you're covering, because though there's higher costs in those areas to provide service. Next slide. In this section, it talks about service area and response times. So average trip time, and this is something that a lot of agencies don't actually record today. And so it's important to make sure that your dispatch system or maybe your EMR system is set up to be able to capture what is your actual true trip time. So how that is defined is the time the organization, from the time the organization begins its response to when that ambulance is available to take another call. Not necessarily when that call was complete, but when was that call completed in a sense that you were back to your service area where you could receive your next request. So an example here would be, we routinely in Michigan do long distance transports. So I might pick up a patient in Grand Rapids, Michigan, and then I'm going to drive 100 miles across the state to drop them off at a specialty level hospital. Okay, they're going for some sort of specialty care or surgery or intervention. Once I drop that patient off, my trip time is no longer done, right? Because I don't have that primary service area. So it's not until I get back into my county that I am available to take the next call. It's likely that now I'm going to be able to respond. If I'm 4 counties away and a 911 call comes in, I'm not going to be able to respond to that call. So that total trip time is really important to make sure that you're capturing, because there's a lot of cost that is wrapped up in that total time on task. Question came in. Our service provides service in several different zip codes almost equally in our county. How do we handle this? Can you answer that live? Our service provides service at several different zip codes almost equally in our county. How do we handle this? I would enter all of those zip codes within your primary. Like, I would look at, where do you have a contractual relationship to be the primary provider? And then if you're routinely providing like mutual aid, or you're routinely providing responses within zip codes outside of that, you can report them in. You could report them in both. Brian, do you have anything to add to that, or?
No, I would agree with that answer.
Hopefully Beth, that answered your question. If not, let me know. Okay, so then it goes into what your emergency response times are. So we've already said in minutes, what's your average total trip time? And now we're going to look at from an emergency standpoint. So they define response time as the time from when the call comes into dispatch to when the ambulance or another EMS vehicle arrives on scene. And then they ask, do you define it this way? And if you don't, then they give you some other options here to use. And then they continue to go on and ask, is your organization required or incentivized to meet response time targets? So for instance, in one of our contracts, if we don't meet our response time requirements, then we have to pay a penalty. Some agencies might actually receive, they might actually receive an incentive payment if they meet their response time. So it could go either way, yes or no. Now for us, if we have to pay a penalty, I'm going to say yes here. I am penalized, and then I'm going to report those penalty fees later on when we get into costs. Next slide. So now we're into section 5, which is where it starts collecting volume data. So there's 4 questions here specific to volume, and we're going to walk through each of the scenarios. So the first is total responses. So total number of responses by your organization in the reporting year, regardless of whether a ground ambulance was deployed or a patient was transported. So this is, you received a request for service and you sent either a fire, say you're a fire service, so you send a fire truck, right? Or maybe you send a first response vehicle, or you also send an ambulance, okay? In that scenario, you send a fire truck, first response vehicle, and an ambulance. That's going to count as one total response, okay? Now, this doesn't matter if it's a ground ambulance, defined as an ambulance. This is for your organization. How many total requests for a response did you receive? Then we break it down into ground ambulance specific. So then they want to know, of those total responses, how many did you respond to that with a ground ambulance? So it was a fully equipped and staffed ground ambulance. It was either scheduled or unscheduled, with or without a transport. So we're not interested here if you actually transported the patient, but you arrived on scene with a ground ambulance. If more than one vehicle is sent to the scene, you're going to count that again as one response. So think of like an MCI situation. You might send 6 ambulances to that scene, but that's going to count as one response. Then from the response, they want to know how many actually resulted in a ground ambulance transport. So you might have had 2 responses. One was a ground ambulance response, and then you had 1 ground ambulance transport. Then from there, it's how many of those were paid by the time the data is reported to CMS. So you may not have received a payment yet on all of your transports that you had for that collection period. But when you go to report your data to CMS within that 5 months of your either finishing calendar year or the end of your fiscal year, you're going to need to report in that period how many of those were paid at 1 penny or more. So not paid fully, but you received some form of payment or cash or revenue that would count as 1. Next slide. So then they want to know how many responses did you have with the non-transporting agency. So you may not even do this, but does your organization respond to calls with another non-transporting agency, such as a local fire department? Yes or no. If no, then you don't need to enter the percentage. But if yes, they want to know how many of those calls, or what is your best estimate, actually involved a non-transporting agency. And then they ask for what percentage of your ground ambulance responses were in your secondary service area. Again, they want to make sure that they're accounting for the volume that is outside of where you're expecting to need to respond, because there can be additional costs sometimes associated with having to go outside of our primary service area. In fact, there is. And then they want to know how many of your total ground ambulance responses did not result in a transport. So these are going to be your treat no transport. Maybe the patient is pronounced on scene, maybe they AMA. They're going to want to know a number here as well, if you can carve those out. Standby events, they do ask whether or not you perform standby events. These are medical standby events, so you would say yes or no. It's not a number here, but yes or no. One thing to note when you're looking at your volume, a standby event would count as a ground ambulance response or transport only if you provide medical care to a patient. So I might provide standby coverage at a 5K run in my community, but I'm not going to count that in my ground ambulance volume unless a patient approaches me, I provide some level of service, maybe a transport or a treatment on scene. I'm going to include that in my volume. Paramedic intercepts are specific to the New York, and for this purpose, it's specific to the definition that only impacts New York providers. Most common for all of you is probably going to be what you would call an ALS joint response. So that's where you're providing an ALS intercept for a BLS crew. They are going to ask if you do provide that, and then they want to know, what's the number of those. And you're not going to include here if you billed for the service, right? Because that would be a ground ambulance transport and then paid ground ambulance transport. Something to note is throughout the tool, you want to make sure you're not duplicating data that you're providing or duplicating numbers. If you already reported it in your total volume, then you don't necessarily want to be reporting it here as well. Section 6 gets into the service mix, and this is where they're going to look at what was your total emergency versus non-emergency volume. For the purpose of the instrument, emergency is considered an immediate response to either a 911 or an equivalent request. And then non-emergency would be, it was pre-scheduled or it wasn't a 911. It didn't require that immediate response. SCT and specialty care transports can count as an emergency. So if you had to respond right away or you have a protocol that for interfacility transfers that require you to respond as an urgent, you can count those also as ALS2 or SCT. So this is percentage, so they're just specifically looking for is 50% of your volume emergency and 50% is not. You might have 0% non-emergency volume, and that's okay. Maybe you only provide 911 services. Putting 0 in there is okay. You'd just be reporting that 100% of your volume is emergency only. The next part of the section is where it breaks it down by procedure code or service level. So what percentage of your ground ambulance transports was ALS or BLS non-emergency, BLS emergency, ALS non-emergency, ALS emergency, ALS2, and then SCT. And this is based on how you build the charge. And this is percentage only. And then they want to know what of your total transports, what percentage are actually going to be an interfacility transport. And interfacility is based on the Medicare definition of facility. So that could be like a hospital, nursing home, rehab, psych hospital, any of the above. You would need to report that percentage as well. And I'm going to turn it back over to Brian for section 7, which is labor, which is a pretty hefty section. So.
All right, thank you, Katie. So, whoop, I apologize, I jumped there. So, Katie is correct. Section 7 is by far the largest section in the tool. So the good news is once you're through with this section, it's all downhill from there. So a couple of things that will definitely help you get through this section with the least amount of confusion is this is only your employees, meaning those individuals which are W-2 employees. This is not looking for independent contractors or any other person that performs services for you pursuant to a contract. So for instance, this is not looking at if you employ a billing agency, the employees of your billing agency. This is only your employees. And then the other sort of big ticket item just to keep in the back of your head as you go through this section is labor is going to be divided into 3 categories, and an individual can only be in one of the 3 categories. So the easiest one is a standalone category for your medical director. So if you employ your medical director as an employee, you would report that in the category of employee for medical director. If your medical director performs services for you pursuant to a contractor as an independent contractor, meaning you give them a 1099 at the end of the year as an individual, or if you contract with a corporation or another entity, you would not report them here. The other 2 categories are your EMTs and your response staff and your administrative and facility staff. And what you want to keep in mind here is, again, an individual can only be in one of these 2 categories. And the way it works is if they qualify for the EMT or response staff category, even if 99% of what they do is administrative, you would still report them in that first category for EMT or response staff. So one good analogy is to think of this as a bucket, and you would start with the EMT response staff bucket, and then you would allocate every employee that fits into that bucket. And then you would look at the employees that are left and then move them on into administrative or facility staff. So just a list of some of the more common situations in which an individual will be characterized. So obviously your EMTs and paramedics, ambulance drivers, any firefighter that has first response or EMT responsibilities, all of them are going to go in the EMT response staff. If you have an EMT supervisor or a training officer, but at any point during the year they staffed an ambulance, they are part of your EMT and response staff and would be reported as such. The admin facility one are those individuals which have, by definition, no EMT or response duties. So if a dispatcher never gets on an ambulance, they would be part of the administration facility section, right? Your billing staff, your fleet manager, right? The custodian in the building, etc. HR director, things like that. But again, if your HR director also happens to be an EMT, and once that year they got on the truck and treated a patient, then they go into the EMT staff. So it is okay, it is permissible for you to have no administrative staff being reported here. You know, in a situation where it is a relatively small agency and everyone at one time or another will serve on a truck, it is entirely possible that they will have no administration or facility staff. And then again, we talked about that medical director one. And I probably should have mentioned it earlier, but volunteers will be treated as employees for these purposes. So you will characterize them that way. When we look at how we assign compensation, it will then ask separately about those volunteers. So again, as we mentioned, if the individual has any EMT or other response duties, that's the bucket in which they would be allocated, even if primarily they operate in an administrative function. So this is a handy little chart that CMS or the RAND Corporation on behalf of CMS put out just to sort of help you characterize people. But what we found is that for the most part, if you adhere to that general rule, which is if at any point in time they were involved in an EMS response, put them in that category, allocating individuals is not overly complicated. You will then get to a question that will ask, and it's asking in the aggregate. So within the EMT and response staff category, what it's asking is how many individuals had the EMT licensure, how many, and if you're a fire department or a police department or another entity, and in that section 1 that we had discussed earlier, you had indicated that yes, in fact, you have other public safety duties. They will then ask you to define those with public safety roles in addition to their EMS roles, and those without public safety roles. It will then ask you the same questions about EMT intermediates and paramedics, nurses, doctors, and a bunch of other categories. They're asking for aggregate data here. So you would indicate the total number of people that fall within that category, the total compensation that are paid to all people in that category, and then the total hours worked by all people in that category. And to the extent you previously indicated that you have shared services, they would then ask you to provide not only the total hours rendered for ground ambulance, but also the total hours rendered for those other public safety duties. So going back to that sort of Venn diagram that we looked at earlier, the general rule in terms of how we're going to report, and this is true not just for labor, but all of the sections that come after this, is if the individual is entirely devoted or the cost is entirely devoted, maybe the vehicle, the facility, etc., is entirely devoted to EMS operations, you would report the full cost of that. If they have shared duties, you would report their full costs, but then allocate based on the percentage of their duties that are EMS versus that other service. And if it's entirely unrelated to EMS, you wouldn't report it in the first place. So you'll notice, for instance, on here, it will not ask you about a fire chief that has no public safety, no EMS obligations, right? So meaning they never worked on the EMS side of your operations, you wouldn't report them at all. And then you will repeat this for all of the various categories. If you indicated that you have volunteers, it will ask you separately about those volunteers. This is, I believe, the same section, but now you'll notice that in addition, we're just showing you the bottom half of this, and you'll see that now it's also picking up the administrative staff and the vehicle staff and all these other various categories of admin employees, and you'll repeat that same exercise. You'll report the total number of individuals that are in that category, their total compensation, and if you've indicated that they share responsibilities outside of EMS, then you would allocate either the hours or the total compensation between the two. One other thing to keep in mind, and that is if an individual changes their licensure during the course of the year. So for example, an EMT basic passes the paramedic exam and then begins working as a paramedic within your organization, you should keep them in the category at which they began the year at. Now, I assume that becoming a paramedic also carries with it an increase in compensation. You would now report all of that increased compensation, still in that EMT basic category. So really what we're doing is on the first day of the year, we're taking every employee and we're assigning them to a specific category within the EMS response staff. We're going to keep them there, but we're going to take whatever compensation they ultimately earned and report that in total. So there are a number of examples which we are going to skip over, in part because some of them are in painful detail. But again, just as a reminder, you only report compensation once based on that category. You'll then allocate the hours that were used either for their EMS obligations or their non-EMS obligations. And then they, meaning CMS and its contractors, will use that allocation to properly allocate the percentage of their compensation that's EMS related when they factor in what the costs associated with the EMS piece are. So we're just going to, in the interest of time, skip over some of these examples. When we get to volunteer labor, they will ask similar questions, meaning you'll be asked to assign them to either the EMS response side of the equation or the administrative facility side of the equation. They will then specifically ask whether or not your medical director is a volunteer. One of the questions they will then ask you, to the extent you indicate that yes, we do use volunteer labor, is whether or not you provide any compensation to them in a form other than formal wages. So for instance, do you provide stipends or honoraria or some other benefit to your volunteer employees? If so, then you would report that here. Now, one thing just to keep in the back of your head is a lot of the things that might otherwise qualify as stipends or other benefits for volunteer labor would also seemingly fit when we get to some of the later sections of the tool and could be reported there as well. So if you elect to report them in the labor section, which we think is probably the easier way to do this, just be sure that you don't also report it in those later sections. So for example, you may not compensate your volunteers in the form of wages, but you may pay their filing fees with the state to maintain their EMS licensures. They will ask you later on about licensing and registration fees, and you can report it there. But if you reported the stipend, the license fees you paid on behalf of your volunteers here, you just want to make sure that you don't also report it later on in the tool. So this goes back to the, just be mindful of the potential for double counting and try and guard against it. We're just going to skip this one because frankly, I'm not a labor lawyer. And this is one of those questions that if you're asking it, you probably want to talk to your local labor attorney. Again, we're not going to count employees twice. So if a volunteer ends up becoming a paid employee, then you would include them in your paid employee count, and you would report the hours and the compensation that they were actually paid. And then you would remove them from the volunteer category. And then we discussed not counting anything that would fall on the line of stipend to volunteers. And big reminder, don't report any independent contractors or contracted services here. Now, I know we have a question, and that is, our services county owned, and the sheriff deputy responds with us on calls whenever possible. Is there any cost involved? So I think what the question is asking is the sheriff's deputy is responding in the capacity of helping out with the EMS encounter, not for things unrelated to the EMS encounter, like scene control or things like that. If that's the case, then the question becomes, is the sheriff employed by the same entity that you are? So in other words, if your EMS agency is a separate municipal corporation, then you would not report the sheriff's deputy because they work for a different entity, even if both of you are subsidiaries of the larger municipal government. So for instance, I'm in New York. The city of New York municipal government has multiple corporations that operate beneath it. One of them is the fire department of New York, which provides EMS services. The police department is a separate municipal entity. They have different tax ID numbers. So if that's the situation, the sheriff's department and your EMS agency have different tax ID numbers, then no, you would not report the deputy because they're not employed by your agency. If, however, the EMS operations and the sheriff's department are simply departments within the sole municipal government, then yes, you would report the sheriff's deputy as an employee of the municipal government. That's really the reporting entity here. But only to the extent the services they're providing are directly or indirectly related to the EMS operations. If all they're doing is basically ensuring the safety of the larger scene, meaning they're there for traffic control, I think you could probably take the position that that's not really integral to the EMS operations, or probably just ignore it entirely. But in a situation like that, you would have other individuals that are outside the EMS organization that likely would need to be reported. For instance, I'm assuming the county also operates the dispatch center, in which case all of those dispatch employees are employees of the same entity. So, and this is probably a good reminder of a question is, before you even start any portion of the tool, you have to properly define what the reporting entity is. So if the municipal government is unified, meaning there's not a separate entity for the police versus fire versus EMS, etc., then the reporting entity is the municipal government. And every employee, even if they don't work in your building, is potentially subject to being counted in this. So a good example there would be the city comptroller or the county commissioner that oversees basically the checkbook is an administrative employee of the operation, because the reporting entity is the government. And certainly what they do supports the EMS operations. They're the one that signs your paycheck. So if you're municipal owned, this is one of those really tricky questions. So just make sure you clearly define what the reporting entity is. It's whoever owns the tax ID number. So if that includes the sheriff's office, then yes, potentially we would have some shared costs. Good news is we're through section 7. Now we're going to talk about facilities. And again, we're only going to include those facilities that are either directly or indirectly related to ground ambulance operations. And we're not going to include any facilities that are used by your contractors. So if you use a billing agency, their building is not going to be reported here. What we're going to do for each facility is we're going to enter it and name it. Make sure you use a name that everyone in the organization would understand. So the address, if it has a specific name that's commonly understood, that's fine as well. And then we're going to check specific boxes and include certain specific information for each facility. So first, they're going to focus on how you ended up in possession of the property. They're going to ask you if you lease it from another entity. If the answer is yes, then you would check that box. Do you own it, but you have a mortgage on it? In which case you would check that box. Do you own it outright, meaning free and clear, no mortgage? You would check that box. Or was it donated to you? And by donated here, we don't mean I own it and I give it to you and I let you use it. That's a lease. I mean, I owned it and I signed over the deed to you, right? At that point, yes, you would own it outright, but you had no cost of acquisition. That's really what they're getting at here. You would then take the square footage of the facility and then the percentage of that facility that's related to ground ambulance operations. And this will start to make sense when you see a few examples. So if your station house only dispatches ambulances, then all of the square footage of that station house would be allocated to EMS operations. But if it's a fire station that has both ambulances and fire trucks, then you would have to come up with an allocation methodology. And there are a number of different ones you can use. None of them are necessarily better or worse in the abstract. This will really depend on your situation, but In the example we're giving here, there are 8 vehicles housed at that station. So you could divide it and say 2 of the 8 vehicles, or 25%, are ambulances, and therefore that is what we will use as our allocation percentage. Or you could say, look, the fire trucks are far larger than the ambulances, so they take up a greater portion of the garage space, and then you can allocate that way. It's less important how you come up with your allocation and more just that it makes sense to you, it's reasonable, and that you document how you came up with it, right? And then you would have to do the same thing for those common areas. For instance, if the admin office is housed within the fire station, it is likely the case that a larger percentage of the administrative space is attributable to ground EMS operations than fire operations, at least compared to the same space being used for the garage, right? Fire trucks are bigger than ambulances, absolutely. But by the same token, if I do my own billing, I have a billing department for my EMS operations, I may not need a billing operation for my fire. So again, just measure the space and then make an allocation that makes sense given, your specific situation. Depending on which boxes you checked, it will then ask you certain additional questions. So as an example, and I think we have an example here. We'll give you a couple of examples. So this is a situation where the organization has 4 facilities, and it's answered differently based on the specifics of each of those facilities. So the first one, its fire station, it answered that no, it doesn't rent or lease it. No, it doesn't own it, but with a mortgage. No, it doesn't own it outright. Rather, in this case, it was donated for its use. And this may be fairly common in the case of a municipal organization where the larger city government built them a building and allows them to use it, and they're not charging them rent for it. They're then saying that the space is 5,000 square feet. And then they're saying that 50% of that fire station is allocated to ground EMS. So maybe in their case, they have 2 fire trucks and 3 ambulances, and the floor plan is roughly 50-50. That's what they're saying. And then they're saying that no, there's no annual, the question is a little bit confusing in the way it's phrased. They're asking yes or no, are there no annual costs? So answering yes is saying no, we do not incur any costs in owning it. Because again, it's been donated, and because it's municipal, I don't have to pay property taxes on it, right? Then they have their administrative building, which they're indicating that yes, they own outright. It's 4,000 square feet, but only 10% of that is allocated to ground ambulance operations, right? Maybe they have a billing office, but the administrative building also houses their fire training academy, and that occupies 90% of the floor space, right? Then they have 2 garages. The first one, garage 1, they're answering that yes, they own it, but they have a mortgage on it. It's 3,750 square feet, and 100% of it is allocated to ground ambulance. Because they own it outright, they are depreciating that building, and they're claiming $3,000 as their annual depreciation expense and $2,000 in additional cost of ownership. Maybe that's property taxes or something like that, right? And in the case of the second garage, they're renting it. And in which case, again, they're saying it's 4,500 square feet, half of which is used for the ambulance. But now they're basically taking their annual lease payment, which is $30,000 a year, and they're declaring that. So depending on how you indicated you came into possession of the building, there will then be questions as to whether or not you pay rent or not, in the case of a lease, whether or not you depreciate it or not, in the case of a building that you own, and whether or not there are other annual costs of ownership, property taxes, yes or no, etc. When we say other costs of ownership, we're not including utilities here. Those will go in to a different portion of the tool. In fact, they're going to come up right here. So it's going to ask you for the total insurance costs. This is the premiums that you wrote to your insurance carrier for property and casualty. This is not asking about health insurance for employees or anything like that. That's going to go in a separate section of the tool. It's going to ask you for the total maintenance and improvement costs that have been incurred during the year. So if we did maintenance and we didn't use our own employees, to do that maintenance, then we would include the outside payments we made to contractors to do that work, right? So if the garage door needed to be fixed, then we hired an outside agency and they charged $1,000, we would put that $1,000 right here. And then it's going to ask what percentage of that is allocated to the ground ambulance operation. So that garage door is one in which both ambulances and fire trucks pass through. You would allocate based on whatever percentage you allocated the garage space to, right? It will ask you for the total utility costs, broadly defined here. So gas, water, electric, whatever other utilities you're paying, right? And then the total facility taxes that you paid for the year. Don't include, this is one of those where you can get double counted. If your mortgage holder escrows taxes for you, so for those of you with a mortgage on your home, it's not uncommon for you to pay your property taxes on your mortgage statement, and then the bank escrows that amount and then pays it on your behalf to the taxing authority. Don't include an amount here for facility property taxes if it's already embedded in the mortgage costs, right? Commercial mortgages can go either direction. So just make sure you know what's really in that mortgage payment if you have one. If you have multiple MPIs, it is possible that those multiple MPIs share facility space, in which case you need to do potentially two different allocations. So if you have two EMS entities, both of which maybe have a common parent company, the headquarter building likely is allocated, provides services for both of them. You would have to allocate that facility's operations to each MPI. So maybe you say that they each do roughly the same number of trips, they both employ roughly the same number of people, the costs are roughly the same, so I'm going to allocate it 50-50, right? But if each MPI also has shared services, then you have to first allocate the facility to the entity, and then within the entity, allocate that percentage that's attributable to ground EMS. So as you can see, hopefully this is relatively straightforward, but in isolated cases, this can get somewhat confusing. My best advice would be do the best you can. But if you get stuck, this is a good time to mention that the AAA is here to help, and that we do have a helpline that you can certainly reach out to, both through email or, pick up the phone, and we'll do our best to walk through the situation and hopefully help you come up with an answer that makes sense. Now that we've talked about facilities, we're going to talk about vehicles. So there's a couple of straightforward questions. How many vehicles, ground ambulance vehicles? So this is an ambulance as defined under state law. Do you own? And then it will ask you again about how many ground ambulance vehicles do you lease? And then it will ask you to name each of the ambulances. So there are two ways that you can create this list. The first is you can enter each vehicle in the online CMS portal. You should name them in a way that likely makes sense to you. One method that we think makes a ton of sense is to just list the last 7 digits of the VIN number. That way it's unique to that vehicle and there's no question, right? It will ask you to check the box as to whether or not that particular vehicle was used to transport patients in that year. So we start with every ambulance that you own, whether it's operable or not. Then it will ask you to define those that you used in the specific year to transport patients. It will ask you if the vehicle was donated to you or not, yes or no. And then if you answered no, it will ask you what your annual depreciation expense for the vehicle is. And if you indicated that you financed it, it will ask you what the loan costs are. It will ask you if the vehicle was remounted in that year. And if you answered yes, then it will ask you the total cost of that remount. And you will need to do this for each vehicle. As I indicated, one option is to do this through their portal. The other option is to upload a template to the portal. So a good rule of thumb here is if you have, let's say, 20 or fewer vehicles, it's probably 6 on the one hand, whether or not you create an Excel spreadsheet and upload it, or just do it directly on the portal. But if you have, I don't know, 500 vehicles, it's going to be a lot easier to use a template than to go through the portal and report each and every one of them. If you elect to sign up for Amber, and we encourage all of you to do so, one of the nice features in Amber is when you enter the vehicles in Amber, we will create a template that you could then use to immediately upload to CMS. So that's a nice feature if you have a lot of vehicles. For each vehicle that you indicated that you lease, they will then ask you to first indicate whether or not you used it to transport patients in that reporting period. And then if you answered I don't know why it would be no. You'd incur the depreciation whether you use the vehicle or not. But regardless, if you indicate that you lease the vehicle, it will. I think this is well. It will ask you to list the annual lease payments. It wouldn't ask you to necessarily indicate the depreciation. So I think that's just a typo on our part. I apologize for that. So just an example of how this would be done if you have 4 vehicles. In this case, the company is indicating that they own 3 of the vehicles. The 4th one is a water ambulance. No, they don't own it. In fact, they lease it. They used vehicles 2, 3, and the water ambulance to transport patients in that given year. The first ambulance was donated to them, as was the second ambulance. The third ambulance they purchased outright. They are incurring depreciation on the first and third ambulances, and they're listing that amount. And on the first ambulance, the reason why they're claiming depreciation is because they're saying they remounted it that year. And the assumption is that the remount has roughly a 3-year usable life. So they're claiming 30,000 of that 100,000 in remount costs as depreciation in that first year. That third ambulance, they bought it. They're depreciating it. The annual depreciation in this particular year is $35,000. And on the water ambulance, what they previously indicated is that they lease it. Those total lease costs are $40,000 a year. So I know this sounds a little bit confusing, but it's relatively straightforward once you get into it. We've talked about ambulances. Now we're going to talk about other vehicles. They're going to first ask a yes or no question. Do you use other vehicles other than an ambulance in your operations, in your ground ambulance operations? So if you have fire trucks and you use them to respond to medical emergencies, you would answer yes. If you have supervisor support vehicles or quick response vehicles, Ford Explorers that your supervisors drive around in, maybe your paramedics are in fly cars, those Ford Explorers, and they go out to meet your BLS ambulances. You would list those vehicles, and then they would ask for the number of them that are leased versus owned. And this is not just limited to motor vehicles. This would include anything with an engine that you use to respond or support your ground ambulance operations. So they will ask you to list the type of vehicle. There is a pull-down list. It's fairly extensive. So, if you have a golf cart that you use to move equipment around your campus, you would list that here, right? All those various motor vehicles, if you have boats, helicopters that support your ground ambulance, or anything with an engine, right? You would list it, then you would indicate whether you own it or leased it, right? If you lease it, they'll ask you for the type of vehicle, the annual depreciation, which since you're leasing it should be 0, and then the lease payment itself. And then they will ask you what share of the vehicle's miles were traveled in support of your ground ambulance operations as opposed to something else. So for your fire trucks, you would have to figure out what percentage of their responses are to a medical call versus a fire call. Understanding that fire calls may also be medical calls, right? So this is one area where you're probably going to have to come up with a rough estimate, right? And then you could apply that estimate across all of the various vehicles. If you indicate that you own it, they will ask you for not the lease payments, but rather the depreciation costs, right? So a template just some of those examples. I don't think we need to go through it because it's really the same exercise that you did with your ambulances. The only difference being after you've gone through how you own it and the cost of that ownership, meaning either the lease payments, depreciation, loan payments, etc. They're going to ask you to allocate the percentage of the vehicle's use that's dedicated to ground EMS versus your other operations. So that percentage will then be used for them to discount the total costs that are associated. Right. Katie, do you want to pick it up with equipment and consumables? I lost track of where we agreed we would switch.
Certainly will. Thanks, Brian. Okay, so we're starting to get into other costs now. So we've talked about facilities, we've talked about labor, and we've talked about vehicles, which is a large portion of our costs. So now we're going to get into some of our smaller costs. The first is capital medical equipment, and this should be aligned with your organization's policy and what you define capital as. Typically, capital is going to include equipment that can withstand repeated use and has a high cost, like ventilators, monitors, stretchers, that sort of thing. You're going to include what the annual depreciation amount was if you do depreciate those types of equipment. But if you don't depreciate and you're just cash basis only, you would just put the full cost in there that was assumed during your collection period. And then any maintenance fees associated with that equipment and service fees as well. And then consumable medical equipment, that's going to get more into like your bandages, other non-capital medical equipment expenses. And the same theme here, depreciation or total costs assumed, and then any maintenance or service. And then medications, if you are responsible for paying for medications, would be reported in section 10 as well. Again, uniforms, so anything that's non-medical. So you can have capital equipment that's not medical. So like office furniture, think of that, computer systems, the same theme here. So annual depreciation, or if it's cash basis, then cost, any maintenance fees and service costs as well, and then uniforms too. Section 11 gets into other costs. So if we've not already reported it somewhere else in the instrument, then here's where you're going to want to make sure you're collecting the cost associated. So think back to when you looked at labor, you were looking at your W-2 employees, but here's where you're going to include any contracted labor or contracted services. So like a billing service, you contract out your billing operations. And so those employees were not previously reported under labor. This is where you're going to report the costs for the services that you're contracted with with billing, maybe an accounting service, maybe dispatch services are actually contracted. You're going to want to include that here. IT support services, this is just a really small list. The full list is available in the tool and the user guide as well. But it's going to say, did you contract with the service type? If you did, then you're going to check the box and you're going to put in the total cost for that service. And then if you're a shared service model, so again, fire, public safety, police, or hospital, you're going to have to put in the percentage of that cost that was specifically attributed to ground ambulance services. Here, this kind of is continuing on to the list. So if you had any expenses that are related to laundry, you would check yes, and then you're going to have to report here the cost associated with that. Travel for training, funds paid to other non-transporting organization for services, or say you contract with another organization to provide BLS response, you would put that, you'd say yes, and then what's the expense that you incurred for those BLS intercepts for that service that you received. 911 service fees, fees for toll roads. If you have to pay penalties for not meeting your response times, here's where you would report those costs as well. It's something just important to note. Make sure you're not duplicating any costs or double reporting here. So if you've already reported it somewhere else in the tool in the previous sections, you're not going to want to double report it here. So again, making sure that you're sniff checking. And something just to be mindful of is if you have multiple parties at your organization that are helping to collect all this data and say they're entering it into Amber, make sure you're double checking with those representatives that they didn't already include it somewhere else. Next slide gets into, so there's kind of like this other bucket. So in section 11, other costs, you can type in what that cost was. Like say you're not sure where it fits in the previous entries. You do have the ability here to identify it, name it, provide what the total expense was, and then what's the percentage attributed to ground ambulance services. So you have that option as well as kind of like a catch-all. And then section 12 is very simple. It's actually the second to the last section, but really it's looking for what were your total expenses that include all operating and capital costs, including costs for services not related to ground ambulance services. So this is kind of like tallying up all your prior entries that you've already reported. And something that I would just recommend is go to your CFO and take a look at your expense statements or your income statements or whatever they might refer to that, and make sure you're including every single line item. So at the end of the year, what were your total expenses, and make sure that you're calculating and collecting and reporting those correctly within the tool. The last section is revenues. So section 13 is going to cover, okay, so now we've said this is how much our costs were for the collection period, and now we're going to report this is what the revenue received during that same period was. So this is going to include revenues that aren't related to ground ambulance services. Again, if you're that shared model, you're going to include all revenues here. They're going to want to know if you can break down revenue by payer category, which we'll cover. And then can you carve out patient pay from the payer source, from the primary payer? And then something that's kind of tricky they ask is how often do you actually bill this type of payer? So if we go to the next slide, it's going to look for, oh, I think it might be the next one. I don't see the payers. Sorry. Okay. So it's going to actually break down payer category by Medicare, Medicare Advantage. You have to be able to separate those, but if you can't, you can report it all under Medicare, Medicaid, Medicaid managed care, commercial insurance, workers' comp, VA / CHAMP VA, and then there is no auto category, so you're going to want to include auto in your commercial insurance category, and you're going to include the total revenue, and then you're also going to have to tell them whether or not that revenue includes the cost sharing. So if you advance, Brian, 2 slides. What we're talking about the cost sharing is if you're not able to separate out when a patient is paying a portion of the account because it's difficult for your billing system to do that, it's okay to report the total revenue collected received by, let's just walk through this situation. Patient has Medicare Advantage and the patient had a $250 copay on that transport. Pretty common. So when you're reporting your revenue under Medicare Advantage, are you reporting the $250 that you already received from the patient? Is that going to be included in that Medicare Advantage total you're providing? We really would like that carved out because the collections percentage is definitely different. We don't typically always collect cost sharing or copays, deductibles, coinsurance from the patient. So if you can carve that out, try to, but if you can't, it's okay. And it's going to guide you through making sure you're informing the party that's included in that total. Other types of revenues that are reported, if you go to the next slide, this is where you're going to get into like facility contracts. So when it's looking at payer sources, Medicare, Medicare Advantage, Medicaid, Medicaid managed care, you're not going to want to include revenue that was received by facilities for services that you're contracted to do. That's going to go in other revenue. Other revenues that are pretty common are like taxes that are earmarked for EMS services. So do you receive a subsidy to provide EMS services? This is where that revenue is going to be reported. Do you receive revenue for providing standby medical events, for providing education services? That revenue is all going to be reported specifically in the other revenues. And then common theme here, did you receive revenue from this source? Yes or no? What was the total revenue received and during the collection period? And then what was the percentage of that revenue that was specifically attributed to ground ambulance services? Talk through that. So what else on revenues? Membership fees. So this is a really small snapshot of all the options that are actually available in the instrument. But the big thing is, again, kind of along the same theme, going through your expense reports, make sure you're looking at your revenue and crosswalking that to the tool and that you're ensuring that it's been reported so they can get an accurate depiction of, total revenue, total cost. Immediate action items. So we're nearing the top of the hour here, so apologize, but what you need to do today is first you need to understand if you were actually selected. If you're unsure, go ahead and reach out to us. We'll put the email address here in the comments so we can help you verify if your NPI, your organization has been chosen to collect data and respond this year or last, and then we'll assist you with what the next steps look like. Make sure you sign up for Amber. In the slides, we've got more information. We can point you to the website to actually sign up for it, or also look to receive one of those SAVIC grants. And then with that, you'll receive the 1-year AAA membership. Review your PACOS information. We didn't talk about this previously, but provider enrollment chain of ownership system. So PACOS is actually the system that Medicare holds all of your enrollment information in, and you want to make sure that you are going through and reconciling that your PACOS enrollment is up to date. If you're reporting vehicles in your survey that you haven't reported to CMS as actually your agency, using from an ambulance standpoint, you want to make sure you've got all of that covered in your enrollment record. Make sure you're tracking any volunteer time and hours. Make sure you're updating any systems within your billing system or your dispatch system to collect the information that you need to report on. And then make sure you're getting a snapshot of your vehicle mileage, but then also a snapshot of your personnel licensure at the start of your period. Because again, you have to report them where they started at the beginning of your fiscal or calendar year. Brian, anything else to add here?
No, other than, just again, Katie alluded to it on the revenue section, but if you don't have your payers organized by payer type in this way that's similar to how CMS expects you to report it, in our experience, it's a whole lot easier to set them up sooner rather than later and track them that way than to try and go back after the fact and figure out, for instance, what percentage of that Medicare dollars was Medicare Advantage versus fee-for-service Medicare. And that is especially true if you lump Medicare Advantage and Medicaid managed care payments from private insurance companies into your commercial payers. So to the extent you have them set up in a way that aligns with how CMS expects you to report them, it will make life a lot easier for you when it comes time to report. So.
All right, and if you have questions, go ahead and reach out to us at hello@ambulance.org. Otherwise, if you go to the website, ambulancereports.org, there's additional resources that you can provide or find there as well. And then just make sure, if you know that you've been chosen to collect and submit your data, make sure you're enrolling to get that free access to Amber. Because Amber really gives you a lot of more capability to have multiple users going in to report your information. You can start and stop as you want. You can see what you've already reported. Personally, I use the Amber tool for all 3 of our reporting entities. It was really easy to use and made it a lot more user-friendly just for our CFO and other parties that needed to assist with this endeavor. So. All right.
Thank you, Katie. Thank you, Brian, for sharing all of your information and expertise with us. The slides and the NAC certificate were dropped in the chat earlier. If you didn't get a chance to download them or can't find them later on when you need to, feel free to reach out to hello@ambulance.org. And the slides do contain a link to an Amber walkthrough video as well as other resources. All of the links are live And the recording of this webinar will be posted on the Montana Ambulance Association website within the next 24 to 48 hours. Thank you, everybody.
Thank you.
Thank you, everyone.